Right now, as you listen to this, your body is continuously printing a microscopic physical receipt of your cardiovascular health.
Yes, literally right this second.
Exactly. And it is not hiding deep in some specialized blood panel. It doesn't require a referral to a cardiologist to find. It is sitting right on the tips of your fingers.
Right there in plain sight.
And if you are over the age of 45, ignoring what is written on this physical receipt it could literally cost you your life.
That is the very chilling reality we are confronting today. We are initiating what is probably one of the most urgent medical briefings we have ever conducted on this deep dive.
It really is.
We are drawing entirely on the clinical data of Dr. Ben Walker. He has dedicated over 20 years to preventative health research, specifically tracking the cardiovascular decline of older adults.
2 decades of tracking this quiet decline.
Right. And our mission today is to decode 4 visible, entirely non-invasive diagnostic signs in your fingernails. Because these markers are quietly, continuously recording the exact real-time function of your heart and your vascular network.
I've been poring over Dr. Walker's clinical notes all week, and the terrifying part isn't just the pathology itself. It is the realization that almost nobody is taught how to read these signs.
Nobody.
Not the patients walking around with them, and tragically, in many cases, not even the frontline physicians operating in a standard clinical setting.
We really have to acknowledge the systemic failure of modern clinical practice right from the beginning of this briefing. I mean, if you go in for a standard physical today, you were looking at, what, a 15-minute appointment?
If you're lucky, usually it feels like 10.
Exactly. And in that time, the physician is forced to review your electronic chart, reconcile your medications, check your blood pressure, listen to your lungs.
Deal with the insurance billing.
Right. Address any immediate acute complaints and document the entire encounter. There is simply zero structural time allotted to closely examine the physical integrity of your fingernails.
None at all.
Not unless you present with something so painful or, visually grotesque that it demands immediate attention.
It is so frustrating. It forces the physician to stare at the computer screen instead of looking at the actual human being sitting in front of them.
It's an administrative bottleneck.
Yeah, and because of that bottleneck, life-saving diagnostic information is essentially just trapped in the medical literature. Cardiologists understand these mechanisms, vascular surgeons understand them.
Absolutely.
But the knowledge never trickles down to you, the patient sitting in the waiting room who is actively progressing toward a major cardiac event.
Precisely. And we must frame the demographic urgency of this crisis for the person listening right now. Because if you are in your 30s, your cardiovascular system possesses this enormous functional reserve.
It's highly adaptable.
Highly adaptable. Your heart muscle is strong. Your arteries are elastic. You could have the initial quiet beginnings of arterial narrowing, and your biology will simply reroute the blood flow.
It just compensates.
Exactly.
Yeah.
It will increase cardiac output and perfectly mask that dysfunction. You will look at your hands and see absolutely nothing.
But the architecture changes as we age. By the time someone reaches their late 50s or early 60s, that elasticity is just gone.
The reserves have drastically narrowed. After 6 decades of continuous efficient pumping, the body's not necessarily broken, but the margin for error, what we in the field call the window for a quiet dysfunction, is practically non-existent.
The window just slams shut.
It does. When the cardiovascular system begins to struggle at this stage of life, it can no longer compensate silently. It is forced to show its hand.
Wow. Literally show its hand.
Literally. So for the adults over 45 who are listening to this briefing, you are actively in this critical window.
Knowing that the margin for error is gone, I keep coming back to a central question here. How is it biologically possible that the body has this built-in, highly accurate cardiovascular warning system, one that requires zero equipment to read, yet we have completely abandoned the art of physical observation to look for it?
It is largely a byproduct of our reliance on high-tech diagnostics. We have been conditioned to wait passively for the MRI or the specialized lipid panel to tell us we are sick.
We want a machine to print out a number.
Right. But your vascular biology does not lie. The nail is a direct physical extension of your central cardiovascular health.
So I want to look much closer at the exact biological mechanism tying the finger to the heart. We understand the systemic failure of the 15-minute visit, but how does a rigid piece of keratin on the absolute farthest extremity of the body reflect the struggle of a muscular organ pumping in the center of the chest?
The answer lies in microvascular fragility. Your nails do not simply materialize out of thin air. They are actively manufactured by a highly sensitive biological structure called the nail matrix.
Okay, the matrix.
Right. This is a specialized layer of living, rapidly dividing cells situated just beneath the base of each nail, right underneath the cuticle. And the key here is that these matrix cells are in relentless, demanding contact with your bloodstream.
They are essentially a cellular factory. And I imagine manufacturing that hard keratin requires an immense amount of metabolic energy.
An unbelievable amount.
Yeah.
And to maintain that production, the matrix responds instantly to the precise oxygen saturation of your blood and the physical pressure driving that blood forward.
So the delivery system for this factory is the capillary bed situated right beneath the nail.
Exactly. And these capillaries are extraordinary structures. They represent the absolute tiniest blood vessels in the entire human anatomy.
To really visualize the scale here, these vessels are roughly, what, 5 to 10 micrometers wide?
Yes, incredibly small.
Right. And a single red blood cell is about 8 micrometers wide. That means the vessels are so unbelievably microscopic that the red blood cells literally have to fold themselves or line up single file just to squeeze through the passage and deliver their payload of oxygen.
It is an extreme microscopic bottleneck, and that is exactly why they are the very first biological structures to fail.
The very first.
Yes. When your central cardiovascular system, meaning the heart and the major aorta, begins to experience functional decline, it initiates a strict triage protocol.
It goes into survival mode.
Exactly. It prioritizes the core. The body will always protect the brain, the heart muscle itself, and the vital internal organs. To maintain pressure and oxygenation in that core, the body will ruthlessly sacrifice the periphery.
So think of the human circulatory system like the water grid of a massive, sprawling city.
That's a great analogy.
When the central pumping station downtown starts to lose its mechanical pressure, the massive, wide pipes under the city center are still going to flow just fine.
Right. The core is protected.
The people living right next to the reservoir will not notice a single drop in water pressure, but the tiny terminal pipes out in the furthest, most remote suburbs, they dry up immediately.
Instantly.
The pressure vanishes there long before the engineers downtown realize the pump is failing. And your fingertips and that microscopic capillary bed under the nail matrix are those furthest suburbs.
That is the precise mechanistic reality. The body is highly intelligent. It does not pull vital resources away from your extremities for no reason.
It's making a calculated choice.
Exactly. When you begin to observe changes in the nail bed, it is an absolute guarantee that the central pump is already having to make severe physiological compromises. The quiet dysfunction has finally breached the surface.
So if the central pump is failing to deliver, we need to urgently shift to what that failure actually looks like visually. Dr. Walker's research identified 4 specific progressive visual changes. And the first sign is essentially an oxygen crisis.
Yes, in clinical terms, we are talking about cyanosis.
Cyanosis.
Cyanosis is a critical diagnostic indicator. It describes a distinct bluish or deep purplish tint that becomes highly visible directly through the translucent nail plate, generally concentrated right near the base of the nail.
But we must make an immediate distinction here, right? Because there are 2 distinct classifications of cyanosis.
Yes, and understanding the difference dictates whether you are dealing with a gradual systemic decline or an immediate absolute threat to your life. We're differentiating between peripheral cyanosis and central cyanosis.
Let us examine peripheral cyanosis first.
Peripheral presents when that bluish or purplish color is isolated exclusively to your fingernails or your toenails. If you were to walk over to a mirror right now and open your mouth, your lips, your tongue, and your mucous membranes would all appear a healthy, well-perfused pink.
So the core is still getting oxygen.
Yes, peripheral cyanosis develops quite slowly over weeks or months. It indicates that local circulation to the extremities is severely compromised, but the blood leaving the heart is adequately oxygenated.
Okay, so it is a profound warning of vascular failure, but it is not a situation where you need to call for an ambulance that very second.
Correct, but central cyanosis is an entirely different clinical entity. This is when the bluish tint is not only visible on your nail beds, but it has aggressively spread to your liver, the underside of your tongue, and the inside of your cheeks.
Oh, wow. So if you see that...
If you observe this, you are in the midst of a medical emergency. Do not wait. Central cyanosis dictates that the blood actively leaving the heart is fundamentally lacking oxygen. The central oxygenation process has collapsed.
I want to make sure the underlying mechanism of that color shift makes complete sense to everyone listening. Why does a lack of oxygen actually turn human tissue blue or purple?
It all comes down to the behavior of hemoglobin. That's the protein inside your red blood cells that actually carries the oxygen molecule.
To transport vehicles.
Right. When hemoglobin is fully saturated with oxygen in the lungs, its molecular structure reflects bright red light. That is why healthy arterial blood is that vibrant crimson color.
But when it loses the oxygen,
When hemoglobin dumps its oxygen, or if it fails to pick it up in the first place, its physical shade actually changes. Deoxygenated hemoglobin absorbs red light and reflects blue and purple light back through the skin.
so if we are looking at peripheral cyanosis, just the nails turning purple, the lungs are doing their job, the heart is oxygenating the blood, but the vascular pipes are failing to deliver that crimson blood to the end of the line before it becomes entirely depleted of oxygen.
Precisely. The blood is moving so sluggishly through the extremity that the local tissues just relentlessly extract every last molecule of oxygen out of it.
They're starving.
Yes, and it leaves only that dark, deoxygenated hemoglobin sitting stagnant in the capillary bed. Now, in the older adult population, clinical research heavily links persistent peripheral cyanosis to chronic, unrecognized lung diseases that place immense back pressure on the right side of the heart.
But there is an even more common pathology here, isn't there?
There is. The most dangerous and most frequent underlying pathology is early-stage heart failure.
Heart failure. I mean, just hearing that phrase is terrifying. But the true danger isn't just the failure of the organ, is it? It's the absolute silence of the disease's progression.
The statistics surrounding heart failure in the over 60 demographic are staggering and remains one of the most chronically underdiagnosed conditions in modern medicine.
Why is it so underdiagnosed?
This is a tragedy of symptomatology. We are conditioned by television and movies to believe that heart disease announces itself with sudden, crushing chest pain or a dramatic collapse to the floor.
Right, the dramatic clutching of the chest.
Exactly. But early-stage heart failure does none of that.
There is no Hollywood heart attack. The heart muscle simply loses its mechanical efficiency over time. The walls might become too stiff to fill properly, or maybe too weak to pump forcefully.
Yes. And the body senses this drop in cardiac output. And brilliantly, but tragically, it begins to mask the failure.
And it covers it up.
It intentionally restricts the blood vessels in your limbs to keep the central blood pressure elevated. It literally forces the decline into silence.
It masks the failure until it physically cannot compensate anymore. We see this exact scenario in Dr. Walker's clinical files. We really must examine the case of Frank. He was a retired postal worker residing in Sarasota, Florida.
Frank's clinical history perfectly exposes the psychological danger of minimizing these physical signs.
Frank is a perfect example because he did what almost every single adult does when faced with physiological decline. He noticed for nearly a full year that the bases of his fingernails were carrying a distinct purplish tint.
A full 12 months.
12 months. He saw it mostly in the mornings or when he'd been sitting still for an extended period of time.
And his reaction was to rationalize it. He blamed the air conditioning in his house. He blamed the mild Florida winters. He convinced himself he just naturally, quote-unquote, ran cold because he was getting older.
It is genuinely horrifying to witness. Frank lived with a glaring biological alarm bell of cardiac failure painted across his hands for 12 entire months, and he successfully dismissed it as an inevitable byproduct of aging.
His own psychology was his worst enemy. It was actually his adult daughter who finally intervened.
Thank goodness for her.
Truly. She flew in for a visit, sat directly across the table from him, and immediately noticed the distinct cyanosis on his hands. She possessed the critical objectivity that he lacked.
She wasn't used to seeing it every day.
Right. She refused to accept purple fingernails as a normal part of aging, and she demanded he escalate the issue at his next physical.
And that external pressure finally forced the clinical machinery into action. His primary care physician observed the peripheral cyanosis and, recognizing the marker for poor cardiac output, immediately ordered an echocardiogram.
Which is exactly the protocol.
Let's explain what that test actually reveals for the listeners. An echocardiogram isn't just a static picture like an X-ray. It uses ultrasound waves to create a real-time, moving visualization of the heart muscle in action.
It is an incredible diagnostic tool. It allows the cardiologist to see the valve snapping open and closed. And critically, it measures a metric called the ejection fraction.
The ejection fraction, that's a crucial number.
It is the exact percentage of blood that the left ventricle forcefully pumps out with every single contraction. Now, a healthy heart pumps out about 55 to 70% of its volume.
And Frank's?
Frank's ejection fraction was plummeting. The echocardiogram definitively caught early-stage heart failure.
But it caught it while the window for intervention was still open. That is the key here.
Yes. Because they identified the pathology through the cyanosis on his nails, his care team could implement precise, targeted medications to reduce the physical workload on his failing heart, alongside aggressive lifestyle modifications.
So they took the strain off the engine.
Exactly. They stabilized his cardiac function. The data strongly suggests that Frank was statistically guaranteed to suffer an imminent catastrophic acute decompensation, meaning a major hospitalization within the following year.
Wow.
His daughter's observation of his hands entirely prevented that outcome.
That is just incredible. Frank's intense rationalization, blaming his symptoms on the cold, convincing himself it was just part of getting older, that points to a much broader psychological blind spot we all have.
We'll do it.
But biologically, cyanosis is an issue of the blood lacking oxygen. What happens when the blood is perfectly oxygenated, but it simply cannot reach the nail matrix because of a physical barricade?
Now we are shifting to the second progressive sign, the systemic plaque threat.
The physical barricade.
Yes, and the visible marker presenting on the hands is severe brittleness and arrested nail growth.
We have to define exactly what this deterioration looks like because people so often mistake it for a simple cosmetic issue. We were talking about nails that suddenly become incredibly fragile.
Yes, very fragile.
They break if you lightly bump them against a kitchen counter. They begin peeling off in thin, dry layers. You might see deep vertical splits running the entire length of the nail from the cuticle to the edge.
Or, perhaps most alarmingly, the metabolic machinery simply shuts down entirely and they stop growing. You might realize a full month has passed and you haven't needed to use nail clippers even once.
What you are witnessing there is biological starvation. The cellular factory we discussed earlier, the nail matrix, is being systematically deprived of the vital nutrients and the oxygen-rich blood flow it absolutely requires to manufacture healthy keratin.
The construction site is open, but the supply lines have been entirely severed.
And the culprit cutting off that supply line is absolutely devastating.
In a massive percentage of older adults presenting with this sudden brittleness, the underlying pathology is a highly lethal condition known as peripheral artery disease, or PAD.
I really want to spend significant time unpacking the pathophysiology of PAD. The implications of this disease are so vast, yet it is wildly misunderstood by the public. PA occurs when atherosclerosis, the buildup of plaque, begins to physically choke off the arteries supplying the extremities.
We must look at how this plaque actually forms because it's not just fat floating loosely in the blood.
Right, it's not like grease in a pipe.
No, it begins with microscopic damage to the endothelial lining, which is the inner wall of the artery. In response to that damage, cholesterol, lipids, calcium, and inflammatory cells begin to embed themselves directly into the arterial wall itself.
It becomes part of the anatomy.
Exactly. Over years, this forms a hardened, calcified barricade that progressively narrows the physical diameter of the vessel. The blood simply cannot push through the barricade to reach the nail matrix.
And this leads to a chilling biological truth that most patients never fully grasp. The exact same calcified plaque that is quietly barricading the arteries in your arms, starving your fingernails and causing them to peel and split, is the precise same plaque that builds up in your coronary arteries to trigger a massive widowmaker heart attack.
It is identical.
It is the exact same plaque that barricades the carotid arteries in your neck, leading to a catastrophic ischemic stroke.
Atherosclerosis is a disease of the entire vascular tree. Plaque is highly systemic. It does not magically isolate itself to your fingertips.
Everywhere.
Yes. This is why a diagnosis of peripheral artery disease is viewed by the cardiology community as one of the absolute strongest predictors of a future major adverse cardiovascular event. If the terminal arteries in your arms or legs are choked with calcified plaque, your central life-sustaining arteries are almost certainly heavily compromised.
But I have to challenge the timeline of this pathology. If PAD is this systemic, glaring marker for imminent heart attacks and strokes, how is it possible for a person to be in such severe, life-threatening danger while the disease remains completely silent for years? I mean, how do you not feel your own arteries turning to stone?
That is the ultimate tragic misconception. The disease is absolutely not silent. The patient's biology is desperately waving red flags, screaming for intervention, but the patient is entirely illiterate when it comes to the language of their own body.
They just don't know how to read it.
Right. In preventative cardiology, we do not look at a single symptom in isolation. We look for a highly specific cluster of symptoms. We call it the triad of warning signs for PA.
Let's lay out the triad. Because if you are experiencing these three things simultaneously, your vascular system is in a state of emergency.
Marker number 1, the sudden onset of brittle, peeling, chronically slow-growing nails.
Okay.
Marker number 2, extremities, specifically the hands and feet that are chronically cold to the touch and take an exceptionally long time to warm up, even when you enter a heavily heated room.
And the third?
Marker number 3 is a highly specific clinical presentation known as claudication.
Claudication. That is a term most people have never heard. Describe the precise physical sensation the patient experiences when that happens.
Claudication manifests as a severe cramping pain or a profound sensation of heaviness and fatigue in the muscles of the legs, typically the calves. But it is entirely exertion dependent.
Meaning it only happens when you move.
Yes, it occurs when you demand more from the muscle, walking up a steep incline, climbing a long flight of stairs, or walking a specific repeated distance.
So, as you ask the muscle to work harder, it naturally demands an immediate surge of oxygenated blood. But because the arteries are choked with plaque, that surge just cannot arrive.
Precisely. The muscle is physically suffocating. It is forced to switch to anaerobic metabolism, which rapidly builds up lactic acid, causing that intense cramping and burning sensation.
But the pain goes away, right?
Yes, the diagnostic hallmark of claudication is that the pain consistently and rapidly resolves almost the moment you stop walking and rest. The demand for oxygen drops back down to a baseline level that the narrowed, plaque-filled arteries can barely handle, and the pain subsides.
Brittle nails, freezing extremities, and exertional leg cramping. That triad is a massive biological alarm. Let's look at the clinical case of Eleanor to see how easily this triad is ignored in the real world.
Eleanor was a vibrant woman in her late 60s, a lifelong gardener living in Burlington, Vermont. Over the course of a few months, she watched her fingernails completely deteriorate.
Just fall apart.
They lost all their structural integrity. They were splitting vertically down the center and breaking off below the quick if she applied any pressure at all.
And her psychological response was identical to Frank's. She found a convenient external excuse. She blamed the brutally dry Vermont winter air. She blamed the abrasive gardening soil she had her hands in all spring.
She treated a profound vascular crisis as a minor cosmetic annoyance.
Yeah, treating it with useless drugstore nail hardeners and over-the-counter biotin supplements.
She was attempting to spackle over a collapsing foundation. The medical intervention only occurred during a routine, heavily rushed checkup. Almost as an afterthought, as she was gathering her coat to leave the exam room, she casually mentioned to her physician that her legs had been feeling unusually heavy when she walked up the steep driveway behind her home.
Just an offhand comment?
Yes. She noted that she was having to stop and rest halfway up the hill, a limitation she had been experiencing for roughly 18 months.
Fortunately, her physician immediately synthesized the clinical data. Piecing together the complaint of brittle nails from a previous visit with this classic description of claudication, the doctor ordered an ankle brachial index test, or an ABI.
The ABI is a brilliantly simple, non-invasive diagnostic tool that explicitly measures arterial blockages. The clinician places standard blood pressure cuffs on both of the patient's arms and additional cuffs on both ankles.
Just 4 cuffs total.
Right. And using a highly sensitive Doppler ultrasound wand, they listen directly to the blood flow and measure the systolic blood pressure in all 4 extremities.
The underlying physics of the test are really fascinating. By dividing the pressure reading at the ankle by the pressure reading at the arm, you generate a specific ratio. In a healthy, unobstructed vascular system, the blood pressure at your ankle should be identical to, or even slightly higher than, the pressure in your arm.
But if the systolic pressure at the ankle is significantly lower than the arm, it is absolute physiological proof that there is a physical barricade, a massive buildup of plaque somewhere in the arterial pathway between the heart and the leg.
And Eleanor's test.
Eleanor's ABI ratio confirmed moderate to severe peripheral artery disease.
The tragedy embedded in Eleanor's file is the sheer volume of lost time. Her deteriorating nails had been visually warning her of systemic plaque buildup for 2 entire years before that offhand comment led to a diagnosis.
2 years.
That is 24 months where the calcification was actively progressing, narrowing the vessels, and pushing her steadily closer to a catastrophic cardiovascular event.
But once the diagnosis was confirmed, the clinical trajectory changed entirely. She was placed on aggressive, supervised vascular walking programs designed to force the body to build new, collateral blood vessels around the blockages.
To create a detour for the blood.
Exactly. She was initiated on targeted statin therapies to stabilize the volatile plaque. Her statistical risk of a stroke was dramatically reduced, but she surrendered 2 years of vascular health because she believed she simply needed a higher quality hand lotion.
2 years of ignoring the physical receipt. We have spent the first half of this briefing focused entirely on passive observation. You observe the deep purple hue of cyanosis. You observe the structural collapse and brittleness caused by plaque starvation. But you do not just have to sit there and wait for these signs to appear. You can actively interrogate your own vascular system.
Yes, we are transitioning to a highly actionable protocol now. Clinically, this is referred to as the capillary refill test.
The capillary refill test.
It is a fundamental rapid assessment tool utilized universally by cardiologists, trauma surgeons, and emergency medicine physicians to instantly gauge the real-time health and pressure of the microvascular system.
I want to break down the physical mechanics of this test so the listener can execute it with absolute clinical accuracy right now.
To ensure an accurate reading, you must first ensure you are in a comfortably warm room and your hands are reasonably warm to the touch. Raise your hand so that it is resting roughly level with your heart.
Level with the heart is critical.
Very critical. You cannot perform this with your arm hanging down by your side, as gravity will artificially pool blood in the fingers and entirely skew the result. Select a fingernail to test the index finger, or the thumb typically provides the clearest visibility.
Now, you're going to take the thumb of your opposite hand and press down directly and firmly onto that index fingernail.
Maintain that firm, steady physical pressure for exactly 2 seconds. If you look closely as you apply the pressure, you'll observe the pink nail bed turn completely white or excessively pale.
It blanches.
The clinical term is blanching. You are manually exerting enough external force to physically exsanguinate the capillary bed. You are literally squeezing all the blood out of that dense microscopic network beneath the nail.
The active part of the test happens the moment you let go. You release the pressure entirely and instantly begin counting in your head. 1, 1,000, 2, 1,000.
You are watching the blanched nail bed with intense focus to see precisely how many seconds it takes for the healthy pink blood flow to surge back into the capillaries.
We must establish the rigid clinical benchmarks for this recovery. In a highly functional adult vascular system, characterized by robust cardiac output and clear, unobstructed arterial pathways, that pink coloration must fully return in under 2 seconds.
Under 2 seconds. The systemic pressure from the heart should immediately flood that microvascular network the microsecond the external pressure is removed.
What is the clinical implication if you let go and the nail bed remains pale for 3, 4, or even 5 seconds?
If the capillary refill requires 3 seconds or longer, and you consistently replicate that delayed result across multiple different fingers, you are looking at a highly abnormal, dangerous physiological response.
It's failing the test.
Yes. It is direct evidence that your peripheral circulation is severely sluggish and lacking adequate forward pressure.
You can immediately corroborate a delayed refill with a secondary physical assessment too, correct?
Yes, you can. Immediately take the back of your hand, where the skin is much thinner and highly sensitive to subtle temperature shifts, and press it gently against your cheek or your forehead.
Okay.
The surface temperature of your hand should very closely match the core temperature of your face. If your hand feels consistently and noticeably colder than your cheek while sitting in a warm environment, it acts as a secondary, undeniable physical marker, confirming significantly reduced peripheral blood flow.
I want to dive deep into the specific biology of what a sluggish refill actually represents. Why is the blood struggling so profoundly to rush back into those tiny vessels?
The test is fundamentally measuring the speed of microvascular recovery, which is entirely dependent on the pressure gradient originating at the heart. When the refill is delayed, it indicates that the mechanical force driving the blood from the central pump all the way out to the extreme periphery is failing.
And the pathologies associated with that are severe.
Extremely severe. We are looking at drastically reduced cardiac output, meaning the heart muscle itself is weakening. We are evaluating an elevated global risk for stroke. And crucially, in the over 60 demographic, a persistently delayed capillary refill is a massive, screaming red flag for an undiagnosed arrhythmia known as atrial fibrillation.
Atrial fibrillation, commonly referred to as AFib. We need to dissect exactly why an electrical problem in the heart physically disrupts the capillary refill out in the finger.
To understand AFib, you must visualize the structure of the heart. It operates with 4 chambers. The top 2 chambers are the atria, which receive the blood, and the bottom 2 are the powerful ventricles, which pump it out.
So it's a 2-stage pump.
Right. In a healthy heart, An electrical signal triggers a strong, highly coordinated contraction in the atria, squeezing a massive volume of blood down into the ventricles. But in atrial fibrillation, the electrical signaling in those upper chambers becomes completely chaotic and disorganized.
Instead of a forceful, unified squeeze, the muscle fibers of the atria just wildly quiver or fibrillate.
Exactly. And because the atria are merely quivering instead of contracting, the blood is not actively pushed forward. Think of the quivering heart like a rushing river that suddenly loses all its current and widens into a stagnant pool.
The momentum just dies.
Because the forward pressure drops massively, the wave of blood leaving the heart lacks the kinetic force to rapidly refill the capillary beds in your fingertips when you release the pressure during the test.
The delayed refill proves the lack of pressure, but the stagnant pool analogy points to the true horror of AFib. When blood stops moving rapidly and begins to pool in those quivering upper chambers, it thickens. It begins to coagulate and form blood clots.
That is the lethal mechanism. If one of those gelatinous clots is eventually pumped out of the heart, it frequently travels directly up the carotid artery and lodges in the brain.
And that causes a stroke.
This causes a massive, highly destructive, and very often fatal ischemic stroke. AFib is a leading cause of catastrophic stroke in older adults precisely because it allows these stagnant clots to form.
Before we induce sheer panic in anyone who just counted 3 seconds on their own finger while listening to us, we have to highlight the clinical caveats Dr. Walker insists upon. A borderline refill time of 2.5 to 3 seconds can absolutely be triggered by benign environmental factors.
Absolutely.
If you perform the test in a freezing cold room, your sympathetic nervous system intentionally constricts those surface vessels to conserve core body heat, which naturally slows the refill time.
Furthermore, if you are actively taking certain prescription medications, specifically powerful blood pressure medications or beta blockers, those drugs are chemically designed to lower your vascular pressure and reduce your heart rate.
So they artificially slow it down.
This artificially induced lower pressure can slightly extend the capillary refill time. This is why the protocol dictates that you must always repeat the assessment in a completely warm environment, with warm hands, testing multiple different fingers to confirm the delay.
But if you control for the temperature, and you account for your medications, and you are still consistently staring at a pale fingernail for 4 or 5 seconds, you are entirely out of excuses. Which brings us directly to the clinical case of Walter, a retired postal worker from Topeka, Kansas.
Walter is the definition of an empowered patient. He had learned about the exact mechanics of the capillary refill test and made the decision to perform the assessment on himself while simply sitting in his living room watching television.
He elevated his hand, pressed down firmly on his index finger, released the pressure, and began to count. 1,002, 1,003, 1,004, 1,000.
It took nearly 5 complete seconds for the pink coloration to fully return to the blanched nail bed. His capillaries were entirely empty, starved of blood for 5 seconds.
He was immediately alarmed, which is exactly the appropriate response. He didn't rationalize it like Frank or Eleanor did. He tested his thumb. 5 seconds. He tested his middle finger. 5 seconds.
He is very thorough.
He switched to his opposite hand to rule out a localized issue. The terrifying delay was identical across both hands.
Walter executed the protocol perfectly. He called his primary care clinic the very next morning. He didn't just ask for a generic checkup. He explicitly articulated to the triage nurse that he was documenting a persistent 5-second capillary refill delay across all digits, and he demanded to be evaluated.
That specific clinical language got him straight through the door. His physician immediately brought him in and performed a comprehensive cardiovascular evaluation, including a 12-lead EKG to analyze the electrical activity of his heart.
And the diagnostic result was definitive and immediate. Walter was diagnosed with highly volatile, completely undiagnosed atrial fibrillation.
And he had absolutely no idea. He was entirely asymptomatic in his daily life. He didn't feel his heart racing. He didn't experience the classic palpitations. He wasn't dizzy.
He felt completely fine.
But his upper chambers were chaotically quivering, the blood was pooling, and his statistical risk of suffering a massive stroke was astronomical.
When you review the cardiology literature surrounding his specific presentation and age profile, Walter was essentially a walking statistical fatality. A clot was inevitable.
It was just a matter of time.
By taking the initiative to perform a simple 5-second physical compression test in his living room, Walter triggered a medical intervention that resulted in an immediate prescription for targeted, life-saving anticoagulant therapy. That blood-thinning medication definitively prevented a major ischemic stroke from destroying his brain architecture within the following year.
The gravity of that outcome is just staggering. He literally saved his own cognitive function, his independence, and his life, utilizing nothing but his thumb and his index finger. It proves how incredibly vital these physical markers are if we actually pay attention to them.
Walter's active observation was life-saving. But there is a structural feature located immediately adjacent to that capillary bed that we have not yet discussed.
Right, the final marker.
Dr. Walker deliberately sequestered this specific data point for the end of his presentation because it is universally acknowledged within preventative circles as the most shockingly overlooked, entirely ignored diagnostic biomarker in human anatomy.
We're turning our focus to the fourth and final sign. We're talking about a structure called the lunula. Most people listening right now have likely never even heard the term, let alone understand the immense biological data it provides.
I want you to physically look down at the base of your fingernail right now. Positioned right at the bottom, sitting just slightly above the cuticle line, you should observe a small, distinct, whitish, highly opaque crescent shape.
It looks like a half moon.
It visually resembles a tiny half moon resting at the base of the translucent nail plate. That specific anatomical feature is the lunula.
It is so commonly dismissed as merely a cosmetic quirk of the nail. Like, people think it's just a pattern, but it is a highly active, crucial biological structure.
The lunula is the actual, physical, visible portion of the nail matrix protruding out from beneath the skin. Remember the cellular factory we detailed earlier, where the new keratin tissue is actively, aggressively being synthesized in real time?
Yes, the
The
matrix.
lunula is the vanguard of that factory. It appears stark white because the tightly packed, newly generated nucleated keratin cells physically obscure the dense pink capillary bed lying directly beneath them, scattering the light.
Before we dive into the pathology of what goes wrong, we absolutely must establish the healthy baseline. If we don't, people will look at their hands, fail to find 10 perfectly symmetrical half moons, and immediately induce a panic attack.
We don't want that.
What is the normal, healthy distribution pattern of the lunula across the human hand?
The biological distribution pattern is highly specific and asymmetric. In a healthy adult vascular system, the thumbs and the index fingers almost universally display a prominent, clearly defined lunula.
Okay, so thumbs and index.
The middle fingers generally possess them, though they are frequently slightly smaller in surface area. The ring fingers exhibit immense variability. Sometimes they're visible, sometimes they're completely absent. And the pinky fingers rarely, if ever, display a visible lunula.
So missing the half moon on your pinky finger is entirely normal biology. The diagnostic alarm bell is not about lacking 10 perfect half moons. The pathological warning is entirely about observing a distinct change from your own baseline.
Exactly. The physiological warning occurs when lunulas that used to be robust and clearly visible on your dominant digits, the thumbs and index fingers suddenly disappear entirely.
They just vanish.
Or when they dramatically shrink and recede toward the cuticle. Or, most critically, when they undergo a profound shift in color, transitioning away from that healthy, opaque white.
Let's systematically analyze these distinct color shifts because the literature shows that each specific hue points to an entirely different, potentially lethal systemic failure. Let's start with the venous system. What does it mean if the lunula shifts from white to a deep red or dark pink?
If the opaque white lunula is entirely overwhelmed by a dark red hue, the clinical cardiology research associates this presentation heavily with congestive heart failure.
Heart failure again.
The mechanism here is intense back pressure. The failing heart cannot adequately pump blood forward, so the venous pressure in the entire circulatory system skyrockets, backing up all the way to the extremities.
It's like a plumbing system backing up.
Precisely. The capillaries beneath the matrix become so massively engorged and distended with trapped blood that the deep red color physically forces its way through the white keratin layer. It's also frequently observed in severe rheumatic heart disease, where the cardiac valves have been structurally destroyed by an autoimmune response.
What if the pathology drives the lunula to turn blue?
A distinctly bluish lunula ties directly back into our deep dive on cyanosis. It is a severe chronic marker of profound oxygen starvation. The hemoglobin reaching the matrix factory is severely deoxygenated, and that dark, hypoxic, sluggish blood becomes clearly visible right at the site of tissue generation.
And finally, what if the color shift isn't dramatic? What if the lunula simply becomes so exceptionally pale that it practically fades away, blending entirely into the surrounding pink nail bed until the defined border simply vanishes?
A profoundly pale, entirely faded, or completely vanishing lunula on the thumbs and index fingers is a classic, deeply concerning clinical marker for severe systemic anemia.
Anemia is a condition that is so dangerously minimized by the general public. People dismiss it as simply having low iron or just feeling a bit fatigued in the afternoons. We have to explicitly detail the immense destructive strain that severe anemia places directly on the cardiovascular system.
Anemia dictates that your bloodstream physically lacks an adequate concentration of healthy red blood cells to carry sufficient oxygen to your body's tissues. The biological mathematics are brutal here.
How so?
If you have significantly fewer red blood cells acting as transport vehicles, your heart is forced to work exponentially harder to meet the body's baseline metabolic demands. To deliver the same required volume of oxygen, the heart must pump significantly faster, and it must contract with far greater mechanical force.
It forces the entire cardiovascular system into a state of relentless overdrive. 24 hours a day, 7 days a week, the heart is redlining just to keep the tissues alive.
This creates what cardiologists call a hyperdynamic state. Over the course of months and years, this relentless excessive workload physically damages the architecture of the heart muscle.
The muscle gets damaged from overwork.
The continuous strain leads directly to left ventricular hypertrophy. The muscular wall of the primary pumping chamber becomes abnormally thick, incredibly stiff, and highly inefficient. This rigid, overworked muscle eventually leads straight to catastrophic heart failure.
It is infuriating to realize that almost no one, including a vast number of practicing clinicians, is adequately trained to examine the lunula for anything beyond a basic fungal infection. We are discarding years of critical early warning diagnostic potential simply because we refuse to look closely at the half moons.
We must examine the case of Dorothy to really understand the gravity of this oversight. Dorothy was a 72-year-old woman residing in Asheville, North Carolina. Her clinical journey is the ultimate example of how easily these vital, life-saving visual signs are casually minimized.
Dorothy was on a casual phone call with her adult daughter, who happened to be a highly trained, registered nurse. During the conversation, Dorothy casually joked, she literally framed it as a humorous anecdote about aging, that her little white half-moons seemed to have packed their bags and vanished.
She thought it was just a funny aging thing.
She noticed she couldn't even remember the last time she had actually seen the white crescents on her thumbs.
Because her daughter possessed rigorous clinical training, she absolutely did not laugh at the anecdote. She immediately recognized the vanishing lunula as a marker of severe physiological strain. She aggressively insisted that Dorothy document this specific observation and explicitly demand an investigation at her upcoming physical examination.
And when Dorothy presented this specific complaint to her primary care physician, to the immense credit of that doctor, they did not dismiss it as cosmetic paranoia. Recognizing the potential for an underlying hematological issue, the physician immediately ordered a comprehensive CBC, a complete blood count, alongside a thorough cardiovascular workup.
The laboratory results from the complete blood count revealed exactly the crisis that the vanished lunulas had been screaming about for months. Dorothy was suffering from a slowly developing, highly significant, and entirely asymptomatic case of severe anemia.
Her numbers were crashing.
Her hemoglobin concentrations were sitting at dangerously low critical levels.
The blood lacked the vehicles to carry the oxygen. But what did the subsequent cardiovascular workup reveal about the toll this was taking on her heart?
The echocardiogram and EKG revealed that her heart architecture was already displaying early, distinct visual signs of profound mechanical strain. The left ventricle was actively beginning to hypertrophy, thickening as it desperately tried to compensate for the massive lack of oxygen-carrying red blood cells.
Wow. That is, you have to pause and deeply consider the terrifying what if embedded in this scenario. What if Dorothy had never made that silly offhand joke to her daughter? What if her daughter had been an accountant instead of registered nurse?
The clinical outcome is highly predictable. The severe anemia would have continued to silently, progressively worsen. The heart muscle would have been forced to beat ever faster and ever harder to compensate for the lack of oxygen.
Until it couldn't anymore.
Eventually, that mechanical strain would have crossed the critical threshold from a reversible compensatory mechanism to permanent, irreversible structural destruction of the cardiac tissue. Based on her blood chemistry and the trajectory of her left ventricular strain at the exact moment of diagnosis, Dorothy was statistically projected to be a maximum of 2 to 3 years away from a major catastrophic cardiac event,
Just 2 or 3 years.
an event brought on entirely by an unrecognized anemic strain. The disappearing lunula was the absolute first and only observable warning sign.
With all four of these profound biological markers now fully exposed and decoded, the subtle oxygen-starved purple hues of cyanosis, the catastrophic structural brittleness caused by the systemic plaque of PA, the sluggish microvascular failure revealed by a delayed capillary refill, and the vanishing or discolored lunula indicating immense cardiac strain. We cannot simply leave you sitting there with this terrifying biological reality.
No, we must synthesize this vast amount of clinical data into a strict, highly actionable framework.
If you are over 45 years old, you need a precise protocol to execute the moment this briefing concludes.
We are concluding this clinical investigation by providing you with Dr. Walker's 30-day triage protocol. This is a rigid, non-negotiable framework for taking aggressive action regarding your vascular health.
Step 1. You must physically examine your hands under the correct conditions. You cannot do this in a dim hallway. Go directly to a window that provides abundant, natural daylight today.
Natural light is essential.
Do not attempt this under a bathroom vanity light or a harsh fluorescent office bulb, as those artificial light sources cast heavy green or blue tones that completely distort clinical color perception. Meticulously note the precise color of the nail beds.
Look for the blue or purple.
Are they a healthy, well-perfused pink, or do you detect the deep blue or purple shadows of peripheral cyanosis? Check the physical structural integrity. Are the nails suddenly brittle? Are they peeling in layers? Have they entirely stopped growing?
And perform the test.
Actively perform the 2-second capillary refill compression test on at least 3 different fingers and time the recovery meticulously in your head. And finally, map out the current state of your visible lunulas. Which specific fingers display them, and what exact color are they?
Step 2. You must immediately take a high-resolution, well-lit photograph of both of your hands resting flat under that natural daylight. We absolutely insist on this photographic documentation because human memory is deeply, fundamentally flawed when attempting to track gradual, insidious biological changes over time.
You just can't trust your memory.
You simply cannot accurately recall exactly how opaque your lunula was 3 years ago or exactly when the vertical splitting began. You require an objective, baseline visual record starting today to compare against future changes.
Step 3. Write down highly specific, detailed clinical notes. Do not arrogantly rely on remembering these crucial details for an appointment that might be 3 months away. Write down precisely which of the 4 signs you observed, exactly which specific finger or fingers are presenting the sign, and provide your best, most brutally honest estimation of exactly how long this physiological change has been occurring.
Step 4. This is the critical escalation and intervention phase. If your examination reveals 2 or more of these 4 clinical signs presenting simultaneously, for instance, you observe severe, newly developed brittle nails alongside a completely vanished thumb lunula, or you document a highly delayed capillary refill presenting alongside the deep purple hues of peripheral cyanosis, do not passively wait for your scheduled annual physical next year.
The wait itself is dangerous.
The wait itself is a massive clinical liability. You must call your primary care clinic within the next 30 days. Demand a phone triage appointment with the clinical nursing staff. Read them your highly specific documented notes and firmly ask to escalate your evaluation appointment.
And when you finally secure that appointment, you must transition into becoming an aggressive advocate for your own survival. Do not just present the symptom. Ask specifically for the appropriate diagnostic intervention.
Be specific.
If you documented a persistently delayed capillary refill, explicitly ask the physician to order an EKG to rule out atrial fibrillation. If you observe the purplish tints of cyanosis, ask for an echocardiogram to assess your ejection fraction. If you are experiencing brittle nails coupled with leg heaviness, firmly request an ankle brachial index test to quantify arterial plaque. If your lunulas have vanished, demand a complete blood count to measure your hemoglobin.
I must interject with a final, absolutely critical medical disclaimer to ensure clinical safety here. Do not, under any circumstances, attempt to definitively self-diagnose major, life-threatening cardiovascular disease based entirely on a single visual sign observed in total isolation.
Right, look at the big picture.
Medical diagnosis is vastly complex. It demands the integration of the full clinical picture. A rigorous analysis of your complete medical history, a deep review of your current pharmacological profile, the presence of other systemic physical symptoms, and a rigorous hands-on physician examination. The ultimate goal of learning this fingernail protocol is not to arrogantly replace your physician's expertise.
Of course not.
The goal is to aggressively elevate you from being a passive, silent patient into becoming a highly informed, vigilant participant in your own clinical care and survival.
Because the overarching, undeniably optimistic thesis of Dr. Walker's 2 decades of research and the entire purpose of this clinical investigation is that entering your 60s, your 70s, and beyond is absolutely not a mandate to simply surrender to systemic decay. You do not just have to accept physiological decline as an inevitable consequence of the calendar. Early detection, achieved by simply looking closely at these microvascular windows, alters mortality outcomes dramatically.
The human body desperately wants to survive. It will relentlessly tell you when it is failing, long before the catastrophic event occurs. You simply have to learn how to read the dashboard.
Your body has been meticulously recording its internal struggles, quietly pushing desperate life-saving signals up to the surface every single day of your life. Today, we finally decoded the silent language of your hands. But it forces you to deeply wonder as you sit there right now staring at your fingers listening to this. What other vital screaming warning signs is your own biology desperately trying to show you, completely unnoticed, simply because modern medicine doesn't have the 15 minutes required to look?